this is the Chief Fitness Officer. I would like to introduce you to Aunt Tori. She's going to be talking about fibromyalgia. Thanks for joining us. Let the show begin.
Hello, everybody. Good afternoon. Welcome. As she mentioned, this is a little combo effort between Evolving Nutrition and Vitanica. So I'm going to be wearing my Vitanica educator hat. So I am a co-owner of Vitanica and the director of research and education and product development for Vitanica. So this is full disclosure, conflict of interest clearly announced, just so everybody's understands that. So we're so happy to be represented by Evolving Nutrition. Evolving Nutrition is a family-owned distributorship. So when you shop at Evolving Nutrition, it's kind of like shopping at your farmer's market instead of shopping at Winco or Walmart, as you would be with a very, very large venture capitalist owned distributorship. So we love to support small businesses like ourselves. And we thank Amanda and her family and Evolving Nutrition and Doreen and everyone there for the collaboration. Okay, so let's talk things fibromyalgia. So this little presentation came about because I've been working on a hope for fibromyalgia formula for us to come out with, because as I bet that you all experience as well as I do, that fibromyalgia is one of those difficult problems, probably one of the most difficult problems to treat. It is, in fact, primarily a women's health problem, and as you maybe have heard me say before, women's health by definition are problems that occur only in women, of course, but also problems that occur more often in women, and then problems that have some unique manifestation in women. And fibromyalgia is in that second category of a long list of primary care problems that occur more often in women than in men. It's actually quite remarkable, the disparity in gender with this particular condition. We now know that this is not an inflammatory condition. This is a disorder of the nervous system, and we're still, of course, learning more and more about it. The diagnosis, there's no real lab tests for fibromyalgia. You have to rule out other things with their presenting symptoms. And the diagnosis is based on the relevant symptoms and some particular criteria. I think I have some of those here, but and some slides, but you can also learn about this criteria. So the symptoms are this widespread pain and tenderness, and really like a sensitivity to touch. Not that light, most likely, but like a normal massage would be likely very painful for a patient with fibromyalgia. And the pain and tenderness can actually move around quite a bit. It can be intermittent. They can have other symptoms: fatigue, insomnia, memory problems, depression, anxiety. And if they have other rheumatic diseases, then they are indeed at higher risk for fibromyalgia. And some patients, like I said, might also have depression or anxiety, headaches of different kinds, some digestive problems, maybe even an overactive bladder, chronic pelvic pain that's not due to other causes, TMJ. These are things that may or may not be going on, and they're not really the part of the diagnosis of fibromyalgia. We just have to be aware that there can be this sort of cascade of effects in other parts of their system. So again, it's not an inflammatory disorder. It's not a rheumatic disorder. It's not a muscle disorder. It's not even an autoimmune condition. This is sort of the status at the moment, and this might evolve, as many things do in medicine, evolve over time. There might be some genetic factor. There certainly is often some triggering things that, it might be a stressor that triggers things. It might be an injury that triggers things. It might be some other chronic spinal pain problem that is a trigger, but that is not the same disease as fibromyalgia. We're going to talk about neurotransmitters, but the neurotransmitters are really, I think, the key at the moment to really addressing this chronic pain syndrome. And what happens is pain is amplified with folks with fibromyalgia. And I probably haven't said anything so far that you don't already know, but just to emphasize that some things that it's not and some things that it is. So it's this central pain amplification disorder, and so the brain is just turned up way too high in regards to the pain. There might be some other causative factors. These are very theoretical or hypothetical, I would say, in terms of, are there toxin as causes or hormone imbalances as causes or viruses or bacteria? It doesn't seem as though there is anything consistent in that department, but since we are still sort of grasping to know enough about how to help people with fibromyalgia, it's good to, I think, keep an open mind. But the neurotransmitters is really where I want to focus today. And of course, we know that hormones can influence neurotransmitter, toxins can influence neurotransmitters, et cetera. So one of the things that they observe in fibromyalgia patients is the low serotonin levels. And there are actually these antibodies that are anti-serotonin that seem to be the cause of this. There are also some polymorphisms in coding for serotonin and COMT, and that also is associated with this high pain sensitivity in patients with fibromyalgia. There can be this increase in the glutamate to glutamine ratio. There's also dopamine is less likely binding and decreases in the precursor uptake, like with tyrosine. So overall, there is low serotonin, there's problems with dopamine. We know those two things for sure about the neurotransmitters that then are ramping up this amplification and sensitivity to pain. Increased glutamate, I think I already mentioned. SSRIs are, well, one in particular is used to treat fibromyalgia. It's the only one that has the indication for fibromyalgia, and I use that at times, and sometimes I find it has some benefit. It doesn't solve all the pain, but it really might take them 30 to 50% of the way. So I like to focus on the serotonin and dopamine in particular, and we're going to be talking about that. Okay, they have also known some hypothalamic pituitary adrenal axis disturbances, which is very intriguing to us alternative minded practitioners. ACTH is often elevated in folks with fibromyalgia. Evening cortisol levels have shown to be higher than normal in fibromyalgia. And this is something we can easily test for with one of those 4-point salivary cortisol tests. I happen to use Labrix by Doctor's Data. They don't pay me to say that, by the way. They are a sponsor of my institute seminars, but I don't receive any compensation from there. And there are others that you might be fond of, but that's who I've come to know and trust, have a high degree of confidence in. So to know what is their evening cortisol, you can test that actually, because it may be that low cortisol levels at other times of the day might be a problem as well. And they've noticed this with serum cortisol. I didn't find any documentation of salivary cortisol, but low serum cortisol and DHEA sulfate also may have some association with fibromyalgia. So again, that 4-point salivary cortisol plus DHEA test, I think, is a really useful test to use in folks with fibromyalgia, because they're likely also to have some sleep problems, and that might help nail that as well. And if we help them with their sleep, we can likely also help them with their chronic pain. But another aspect of the HPA disturbances is that stress can be a trigger for symptoms. And by the way, about these 4 or 5 slides, I got permission from my good friend and colleague, Dr. Marianne Marchese, to use for this. So she says hello. She gave a talk on fibromyalgia a couple, 3 years back at our Institute of Women's Health seminars. So we got neurotransmitters, we've got HPA disturbances. Those are the 2 things I really wanted to focus on today, because we know that we can do something about those things directly. And we know they have evidence of some direct relationship with fibromyalgia. So this is the new Vitanica formula called Fibro Formula. And I'm going to walk us through the data that we have a little bit on magnesium, PEA, 5-hydroxytryptophan, and saffron. So PEA is that palmitoyl ethanolamide. Whenever I have a patient that I'm talking to about PEA, I always so far still have to get my screen on to be able to say palmitoyl ethanolamide, PEA for short. So these are the 4 nutrients and herbs that I decided to focus on for our fibro formula. I feel like this is where the evidence is, even though it's only a small amount of evidence, published, randomized trials. So at least we have something to go on. And then we're going to build on that through some other formulas. We got sleep, right? We got HPA access. We got the neurotransmitters in addition to what this formula can provide. So think of the fibro formula as kind of like the base of what I would want all my fibromyalgia patients to be on. And then we're going to add, as we'll see in a moment. But let me just take you through this a little bit for a minute. So duloxetine is the SSRI that I was referring to that is FDA approved for fibromyalgia patients. And this study was published about 3 years ago. And saffron, which is kind of really climbed the ladder of awareness. We got studies on ADHD and depression, fibromyalgia. What else? Those are the ones that come to my mind at the moment, but there are more. So this was a small study, but 54 patients is not a slouchy number, and they had been diagnosed through the criteria set forth by the American College of Rheumatology, and so they had this diagnosis, and they were given saffron. They were given 1 capsule of duloxetine or 1 capsule of saffron at 15 milligrams a day of a particular extract. That was done for the first week, and then they took 2 capsules of duloxetine or saffron and during the second week and stayed on that for 2 months. So that essentially 2 groups, starting out the first week at the low doses, and then for the next 7 weeks at the higher doses, 2 different groups. So mean scores for all outcome assessments improved after 8 weeks in both groups, and they were not statistically significantly different. So what you have here is saffron worked as well as duloxetine. And that doesn't mean it's curative, but like I said, you might get someone 30 to 50% of the way with just saffron, and 30 to 50% of the way in someone who's in chronic, moderate to severe pain is a big deal difference in their life. Okay, the next thing I wanted to talk about in the fibro formula was the magnesium. Now, this was a study on transdermal magnesium. It was actually applied topically to the lower limbs. And we know that magnesium has some analgesic effects. And we know that it can affect the monoamine oxidase activation of a receptor, the NMDA receptor, which is a protein receptor. And this connection plays this role in central pain sensitization and can reduce spontaneous pain and can alter the response to peripheral stimuli. 5-HTP increases serotonin, and that's really the main shtick here with why it's in a fibro formula. And there was a double-blind study in fibromyalgia patients just with 5-HTP, 100 milligrams 3 times a day, significant reduction in pain. So, and improvement in their sleep, which is not surprising, and their anxiety, which is not surprising. So let's just go back to the fibro formula for a moment. So if we look at the 100 milligrams in 2 capsules. So, and the dosing is 1 capsule twice a day, or frankly, you could take 2 capsules all at once. But the reason why I wanted to go back and look at that is you can always add on more 5-HTP, for example, to that 100 milligrams. So you could add on another 200 milligrams, likely before bed would be the way I would do it. So that would be an example of an add-on to get an even more robust serotonin response. And here's the PEA. This was using duloxetine and pregabalin. That's what DLX and PGB stand for. After 3 months of treatment, they had a decrease in tender points and the pain that was evoked and pain intensity. After 6 months, these parameters had a further improvement. And then they added PEA to the duloxetine and the pregabalin after 3 months of just the 2 medications, and there was significant improvement in pain symptoms with a further reduction in the number of tender points and reduction in pain compared to just the 2 medications alone. So this is another example of sort of add-on. So okay, duloxetine, pregabalin got got you down the road a certain distance, and then adding the PEA was an add-on that further reduced that amplification of pain. So that's very exciting to me about PEA. Okay, so this also, other add-ons that you could do is you could add on our magnesium tonic to the magnesium in the formula. At 2 caps, you're getting of the fibro formula, you're getting 100 milligrams, another tablespoon, you're getting another 300 milligrams. So this takes you to 400 of magnesium bisglycinate, which is from most sources, the most absorbable form of magnesium, and should not cause any digestive yada yada. Now, this is not the topical that was used in the study, so I know we're extrapolating big time, but magnesium is in that pathway of increasing tryptophan, which then increases serotonin. So that is part of the logic for the oral. But I have, and I have not tried topical magnesium products to, particular pain areas. I think I'm going to try that though. I'll look for a good product. And then depression, Vitanica has this depression form has been around quite a number of years in our inventory. We know that St. John's wort increases serotonin, and we know that rhodiola also increases serotonin a bit. We know that lemon balm and ginkgo have been used in published studies for depression. I don't know that I could say it exactly increases serotonin, but we know that B12, B6, and folate do affect the serotonin pathways as well. So this is our combination depression formula. So again, my thinking with my approach has been use the fibro formula as a base, add on uplift, for example, add on more magnesium, for example. And you pick which and how many things you want to add on based on your not just understanding of the disease, but how is the disease fully being manifest in your patient. Like if that patient really is struggling overtly with depression, I'm definitely going to be thinking I better add on uplift, or I better add on more 5-HTP, for example. And then here's a formula you might not be aware of that we've had. Estelle or Amy can remind us how long we've had it. Let's say, I'm guessing around a couple of years. So remember, we called out the 2 neurotransmitters, serotonin and dopamine. And here's the dopamine assist formula to do just exactly that. And we know that tyrosine, the amino acid tyrosine, does increase dopamine. I'm trying to get it in my little Vitanica catalog in front of me as well. And we know that B6 is synergistic in maintaining dopamine, and so the B6, the green tea, the quercetin, and the 5-HT, the folate, the L-methylfolate, they all are involved in restoring neurotransmitter, uh, normal neurotransmitter environment, you might say. Mucuna is a precursor to dopamine, which does cross the blood-brain barrier. So I might even add uplift and dopamine assist, or I might add just our St. John's wort and dopamine assist, for example, if you want to just, I guess, simplify or focus, that would be an option as well. The rhodiola, as I mentioned, is used as for depression. And so here's rhodiola is kind of a cool adaptogen to choose for fibromyalgia because it affects neurotransmitters and it affects that HPA axis. So now we've kind of gotten two things out of one product. And our rhodiola has the 200 milligrams of the standardized extract plus a bonus whole root powder. And then if the fibromyalgia patients I have seem to have a recognizable sleep disorder, and you might not, we can't necessarily know which came first, their sleep disorder triggering their fibromyalgia or their fibromyalgia and chronic pain causing a sleep disorder. Same thing could be said if we did the salivary cortisol 4-point test. Is that causation? Are any abnormal results on their causation of fibromyalgia, or are they results of fibromyalgia? I don't know, but I know that I am motivated to correct it. And so I might use a sleep formula to help them fall asleep and stay asleep. And some of these ingredients do better at one than the other, and some do both. Like valerian, the research shows that it can actually do both, help with sleep latency and maintaining normal sleep cycles. This is our herb only 3-herb combination of a liquid tonic. But I might use sleep blend, so fibro formula, sleep blend to help them sleep, but I will have done my salivary cortisol test to know what else I might need to do. And I'll get to that in terms of cortisol regulation. This is also just in our liquid tonic category. We have quite a few liquid tonics, by the way. And they taste good. They're designed to taste good, but we have, I don't know, at least 10, I think, liquid tonics. So right now, today, we've talked about the magnesium tonic, sleep tonic, and the mood tonic. So if for some reason you don't want those other nutrients in there, you want to just deliver the herbal aspects for mood or for sleep, this is a way to do that. And some people, do get pill weary, and liquids are nice for that person. And liquids are also nice because you can do more variable dosing to have a little bit more control over how much they get. So this brings us to the cortisol. So if I've done the salivary cortisol test and I see, wow, their evening cortisol is elevated, and that's when it's supposed to be lowest. We're supposed to have morning, noon, afternoon, and night. It's the descending curve, and maybe they're like this, or maybe they're the. So dysregulation is really the problem, not just adrenal fatigue, but really adrenal dysregulation. That in this case, what we're talking about is cortisol dysregulation. So this product is meant for especially that evening elevated cortisol, either suspected by you or actually documented objectively by you. That would be preferable. This product, what if their cortisol was elevated at another time of day? You could use it about a half hour before that peak let's say it peaked at noon. It's not supposed to peak at noon. So you could use this, half hour, an hour before noon, and hopefully they won't get sleepy with that, but you're trying to sort of tamp down that cortisol and restore them to a normal cortisol curve. And adrenal formulas, ours is called Adrenal Assist, don't specifically elevate or don't specifically lower a cortisol. It regulates the HPA function. It regulates adrenal function. So that is sort of the tonic, not stimulant, regulating effect of a multi-ingredient adrenal formula. So you don't see in this formula, you don't see a suppressive something like magnolia, which tamps down cortisol, and you don't see the elevating cortisol herbs like licorice or ginseng. You see the adaptogens, the rhodiola, the astragalus, the maca, the ashwagandha, holy basil, etc. You don't see, well, you do see American ginseng here. And if you, so I take it back, you don't see the ginseng. You do see the ginseng, but it's at a low dose, so it's not really a stimulating effect on cortisol. It's the adaptogenic effect. So there are, if I had a salivary cortisol test and it was low in the morning where it's supposed to be its highest, I would be using Adrenal Assist and adding licorice root extract or adding more ginseng or adding, prescription Cortef. I max out at that at 10 milligrams a day. Usually I start at like 2.5 at whatever time of day I want it. And I might be maybe they were low in the morning and low at noon. So I might do 2.5 in the morning and 2.5 at noon. And I'm still doing the adaptogens, Adrenal Assist, but I would never go more than 5 milligrams per dose, and I would never go more than 5 milligrams twice a day. You might find someone else who would say differently, but that's the way I was taught and feel comfortable doing. So last slide, just I have a blog where I post things twice a month, and there's a vast amount of information on there. I've been doing that blog for, I don't know, over 10 years. So there are studies constantly that I read and publish, hopefully a readable, and Estelle helps make sure that they're readable. Summary, interpretation, summary, and comment on those studies. And then sometimes there's other information on tests or commentary on, I don't know, states of things. I wax a little bit philosophical on there. Please do check out our seminars, 4 seminars per year, our meaning the Institute of Women's Health, of which Vitanica is a sponsor, but instituteofwomenshealth.com. We have a seminar coming up towards the end of July, primary care for women. Some utterly awesomely expert speakers, Lori Mankato on asthma and allergies, Elena Guggenheim, and her rheumatologist mother, a whole day of rheumatology. So check that out, please. And then please, like I said, consider ordering from Evolving Nutrition, any of these products and more. A nice, small, family-owned distributorship. Well, do we have any questions? I don't know if we do.
We do. Thank you very much, Tori. That was awesome. And I'm going to go ahead and run through the questions as they came in through chat, and then you answer them.
Okay.
So one of the questions was, what about EDS? Question mark, MCAS question mark,
right,
and small fiber neuropathy.
All right. Well, I'm not sure what they mean by what about, but those are their own entities. So that would be an example of your patient has chronic pain and you need to do your due diligence to rule in or rule out those other conditions. And that's important to know how to do. What is, the evaluation for someone with EDS? Basically, the most common type of EDS, there's no genetic test for that. You have to know your symptoms, ask the right questions, do the right physical exam. There are criteria for EDS, as well as uh, you know, like I said, MCAS, and what was the other one they mentioned? Small fiber neuropathy. Yeah. So we do need to learn how to uh, have an eye out for those conditions and how to assess and evaluate and diagnose those conditions. And remember, someone can have more than one problem. They could have fibromyalgia and EDS. But fibromyalgia is not EDS, is not small fiber neuropathy, and is not MCAS. It's its own separate entity.
Thank you. Next question was, do we get access to the slides? And the answer to that is yes. We will have the slides available, and we are recording this as well. So all of the slides, the presentation and the questions, we will be posting on our website in the educational support section. It usually takes us a couple days to get that up there. As soon as it is, we'll be sending an email to all the participants with that information. Next question for you, Tori. Dopamine assist. Oh, Estelle mentioned that dopamine assist has been around for a few years. So I think there was a question on that during the presentation.
Mm-hmm.
Next question. If a patient is already on duloxetine, are you cautious to add fibroformula with a 5-HTP for fear of serotonin syndrome, or is it not a concern at that dose of 5-HTP?
I am not concerned. And I'll tell you why. I mean, we have my starting argument for doing this is it is very common to prescribe more than one SSRI. And it's common to have high end dosing of one SSRI and then still bring on a second SSRI. So that is within the practice of conventional medicine. So if they get to prescribe 2 of theirs, I get to prescribe 1 of theirs and 1 of mine, is my sort of down and dirty argument. And then you bring up the issue of dosing as well. Yes, but at what dose might someone be sensitive to serotonin syndrome? I don't know, but knock on wood, in 36 to 37 years, I've only had one person that looked like that's what was happening. And they were taking 2 SSRIs and at the highest end of the dosing. And because of their still persistent severe depression, all the other medications they had been through, I added 1, or I think I added SAMe at the time. And that was not a problem, but they on their own then added 5-HTP and St. John's wort. So that is when they kind of got into some troublesome waters. So it's good to know about it. It's good to be alert. And certainly if you look in Up to Date or something, it will say, don't do this and don't do that. But I very commonly prescribe an added herb or nutrient that affects serotonin along with their SSRI. And so far, good.
Thank you very much. Does anybody else have a question? You can either unmute yourself or you can type something in the chat. Okay. Well,
okay. Before you close it out, just I'll say a couple things, and then if something else rolls in someone's mind, they can ask it. But I want to thank Amy and Estelle, 2 main players of Vitanica. Vitanica machinery would not run without Estelle and Amy. So thank you very much, Estelle and Amy. And they're on the call today. And thank you again to you folks at Evolving Nutrition. Really appreciate the collaboration.